Hello, I'm Hematologist Oncologist Dr. Tony Talebi, and this lecture pertains to the Acute Myelogenous Leukemia chapter of Hematology and Transfusion Medicine Board Review Made Simple. Acute myelogenous leukemia is a heterogeneous clonal stem cell malignancy in which immature hematopoietic cells proliferate and accumulate in the bone marrow, peripheral blood, and other tissues. Risk factors include exposure to chemotherapy, especially topoisomerase II inhibitors such as etoposide or adriamycin, which cause translocation 1123, and alkylating agents such as glycophosphamide, which may cause 7q deletion. These two are very important to know. Radiation, benzene, inherited bone marrow failure syndromes such as Fanconi's, Shrock-Lambodian-Diamond, severe congenital neutropenia, and genetic disorders such as Downs. May be anteceded by myelodysplastic syndrome. Those are very difficult to treat and requires more than 20% blasts on bone marrow biopsy for diagnosis. Classification: 8 different types. AML M0 is minimally differentiated acute myeloblastic leukemia. AML M1 is acute myeloblastic leukemia without maturation. M2, acute myeloblastic leukemia with granulocytic maturation. Translocation A21, important because it's a good translocation. M3, Promyelocytic Leukemia, APL. Translocation 1517, important to know. AML M4, acute myelomonocytic leukemia, inversion 16, or deletion 16, important to know. M4-EO, myelomonocytic together with bone marrow eosinophilia, inversion 16, good prognosis. Acute monoblastic leukemia, M5, or acute monocytic leukemia, M5B, translocation 911 mmL, intermediate prognosis to poor prognosis. M6, acute erythroid leukemia, not a very good prognosis. M7, acute megakaryocytic leukemia, important to know, CD41 positive, translocation 122 in children, 3q in adults, not a very good prognosis. M8, acute basophilic leukemia, not a good prognosis. Good risk versus standard risk versus poor risk AML. Case report: 27-year-old female presenting with pancytopenia. Bone marrow biopsy reveals myelomonocytic leukemia M4 with inversion of chromosome 16, FLT3 negative. Status was induction with daunorubicin, 60 mg per meter squared times 3 days, as well as cytarabine, 100 mg per meter squared continuous times 7 days. Repeat bone marrow biopsy on day 14 without evidence of blast. Patient with ANC more than 1,000, platelet count more than 100,000. And these are important because the criteria for complete remission dictates that you have ANC more than 1,000, platelet count more than 100,000. After 1 month of treatment with repeat bone marrow biopsy without evidence of blast. What is the next step in management? This patient has favorable cytogenetics, and we'll go over those, as well as being FLT3 negative, which is a good prognostic indicator, and has achieved a complete remission following enestin chemotherapy. So we'll discuss shortly what to do. But the criteria for complete remission is 1, morphologic CR includes must have absolute neutrophil count more than 1,000, platelet counts more than 100,000, and no residual evidence of extramedullary disease with less than 5% blast in the marrow. Cytogenetic CR, normal cytogenetics. Molecular CR, negative molecular markers. So good risk versus standard risk versus poor risk AML. The favorable prognostic indicators in AML are 1, translocation 821, next translocation 1616, next translocation 1517, next inversion 16. Next, the patient has normal karyotype, then subtyping with NPM1, nucleophosphate membrane 1 positive, SEPPA mutation positive, FLT3 negative. Intermediate prognostic indicators in AML are 1, normal cytogenetics, next translocation 911, next trisomy 8. Poor prognostic indicators of AML are 5q deletion, 7q deletion, complex cytogenetics, more than 3 deletions or mutations, translocation 11q23, FLT3 positive, and version 3. And for the hematology boards, you must know all of these. Treatment of AML, must know dosages. Daunorubicin 60 to 90 milligrams per meter squared, or idarubicin 12 milligrams per meter squared times 3 days, with Ara-C 100 milligrams per meter squared times 7 days. Growth factors reduce duration of neutropenia. Rigorous AML is treated with standard 7+3 induction, followed by 3 consolidation courses of high-dose Talebi at 2 grams per meter squared every 12 hours for 3 days. And that's what our patient was in that case report I just discussed. And allogeneic stem cell transplant is deferred once and if patient relapses only. Intermediate risk is debated. Autologous stem cell transplant may prolong survival or may proceed with allogeneic stem cell transplant consolidation only if there's a matched sibling donor and patient is less than 40 years old. Poor risk AML is treated with induction regimen followed by allogeneic stem cell transplant as consolidation. Relapsed AML. Relapsed AML is treated with another salvage induction cycle of chemotherapy. If duration of remission was longer than 6 months, higher likelihood of achieving a second complete remission with reinduction regimen. Always prefer to have patient in remission prior to transplantation. Then proceed to allo transplant if disease is chemosensitive. If duration of remission was less than 6 months, there's less than 20% chance of achieving complete remission with reinduction regimen. May consider allotransplant up front or a clinical trial. Some salvage regimens include mitoxantrone etoposide, fludarabine, cytarabine, mitoxantrone etoposide, cytarabine, and FLAG-IDA. AML with hyperleukostasis. 40-year-old female presenting with severe shortness of breath and cough. WBC 160,000 with 60% circulating blast. Hemoglobin 10, platelets 90,000. Chest X-ray with bilateral diffuse nodular infiltrates, but no fever. Initiated on oxygen therapy. What to do next? Patients with leukemic blasts, more than 50,000, are at risk for hyperleukostasis syndrome, in which the blast can compete for oxygen in microcirculation and cause infarct of the affected tissue. This is a medical emergency if symptomatic. Very serious if it occurs in the brain, since the hypoxia-induced weakness in the cerebral vessel wall will cause the vessel to rupture and cause a hemorrhagic stroke. Treatment, leukapheresis and hydrea, but also begin investigation to work up AML at the same time. Some recommend waiting until WBC count is less than 50,000 before chemotherapy induction treatment. Leukapheresis this is important to know. Leukapheresis has been reported to be detrimental in patients with acute promyelocytic leukemia, APL-M3, since elevated cytokines released will worsen the DIC. If asymptomatic, consider hydrea. Terminal deoxynucleotide transferase, TDT, and AML. Case report. 75-year-old man presenting with pancytopenia. Bone marrow biopsy with 65% blasts that are myeloproliferative negative, TDT positive, CD19 positive, CD117 positive, CD33 and 34 positive, CD41 negative. Cannot appreciate our rods. This is the opposite of what you expected, and this actually looks like ALL. Remember that in AML M0, however, undifferentiated AML, as well as AML M1, AML without maturation, TDT may be positive. The opposite of what you would expect. But just like in ALL, treatment of TDT positive AML needs to be with AML induction regimen. Just like in the case of ALL, where there is AML features, those patients do not benefit from AML type regimens. If our rods are not present, then it is M0. If our rods are present, then it is M1. If CD41 positive, think M7, Megakaryocytic Leukemia. Acute Promyelocytic Leukemia, translocation 1517M3. Case report. 44-year-old female presents with oozing from the teeth while brushing her teeth. WBC 17,000 with blasts, hemoglobin 8, platelet count 39,000, elevated PT, ATT, low fibrinogen, elevated D-dimer, and fibrin split products. Basically, patients on DIC. No fever and smear blasts with hour rods. Acute Promyelocytic Leukemia, APL, is a biologically and clinically distinct variant of AML. APL was classified as AML-M3 in the older French-American-British classification system and is currently classified as acute promyelocytic leukemia with translocation 1517, the PML-RAR, in the WHO classification. It's characterized by the presence of atypical promyelocytes in the marrow and peripheral blood. Immunophenotype is CD34 negative or partial or weak positive, HLA-DR negative, CD13 positive, CD33 positive, and CD11B negative. An APL variant may exhibit translocation 1117, which is more common in children. And the most important thing, disseminated intravascular coagulation, is frequently present at diagnosis or occurs soon after the initiation of cytotoxic chemotherapy in patients with APL due to cytokine storm. This is very important because the patient can die from DIC in a very curable disease. So absolutely must follow fibrinogen, PTT, PT, and replace aggressively with if fibrinogen level is low, less than 100, with cryoprecipitate, which contains factor VIII, fibrinogen, bone milligram factor, and factor 13, and with fresh frozen plasma if PT and PTT are elevated. Also keep platelets above 30 to 50,000. APL requires confirmation by either RT-PCR, FISH, or conventional cytogenetics that proves the PML-RAR translocation. Prognosis: since the disc revealed all-trans retinoic acid ATRA by the Chinese, which promotes a terminal differentiation of malignant promyelocytes to mature neutrophils, prognosis of APL has improved significantly. Arsenic trioxide, also very effective, but monitored for prolonged QT interval and electrolyte depletion. The 3-year probability of relapse-free survival is in low-risk patients, which is WBC count less than 10, platelets more than 40,000. The RFS is 95%. In intermediate, which is WBC less than 10,000 and platelets less than 40,000, RFS is 89%. And in high-risk patients with WBC count more than 10,000, the RFS is 70%. Treatment, induction, consolidation, and maintenance. The induction phase, low risk, daunorubicin, 50 mg per meter squared for 4 days, cytarabine, 200 mg per meter squared times 7 days, along with ATRA, plus or minus arsenic trioxide. If high risk, higher dose daunorubicin, same with cytarabine, along with ATRA plus or minus arsenic. The consolidation, if complete response achieved with induction, in low risk, 2 cycles of arsenic, 0.15 mg per kg per day times 5 days for 5 weeks times 2 cycles, followed by 2 cycles of daunorubicin times 3 days plus ATRA times 7 days for 2 cycles. If high risk, 2 cycles of arsenic, followed by 2 cycles of daunorubicin plus ATRA, and escalate the anthracycline dose or high-dose ARC. Maintenance, intermittent ATRA, 6-MP, and methotrexate for 2 years. The persistence or reappearance of PML-RAR fusion gene transcripts in patients with APL after induction and consolidation therapy is highly predictive of clinical relapse, and frequent monitoring approximately every 3 months by RT-PCR is considered standard of care. The first relapse, treatment, arsenic trioxide, 0.15 mg per kg IV daily, plus ATRA in divided doses. If patient becomes PCR negative, consider autologous stem cell transplant. Patient remains PCR positive, allo stem cell transplant versus clinical trial. All-trans retinoic acid syndrome, the ATRA syndrome. Case report: 20-year-old male, newly diagnosed with acute promyelocytic leukemia, APL, initiated on treatment with all-trans retinoic acid. In a few days, presents with fever, shortness of breath, cough, chest X-ray with bilateral infiltrates, negative cultures. The WBC count has increased from 7,000 to 35,000. What happened? Patient has ATRA syndrome. manifesting as hyperleukostasis, respiratory insufficiency, fluid retention, and fever. It's thought to be due to release of inflammatory vasoactive cytokines causing capillary leak, fever, edema, rash, and hypotension. Treatment, early recognition. Consider a temporary cessation of ATRA if symptoms are severe, otherwise may continue ATRA, and aggressive management with dexamethasone therapy, 10 mg IV every 12 hours for 3 or more days. Monoblastic Leukemia, M7. Case report. 15-year-old boy presenting with gingival hypertrophy, shortness of breath, WBC 84,000 with blasts, morphology, monocytic, myeloproliferative negative. This is AML M5. You must know all different types of leukemia from M0 to M8. M5 is associated with translocation 911. Treatment, standard induction, followed by allo stem cell transplant consolidation. Megakaryocytic Leukemia, M7. 3-year-old boy presenting with 3-week history of bone pain, anemia, thrombocytopenia. Attempted bone marrow aspirate is unsuccessful due to quote-unquote dry tap. Bone marrow biopsy reveals blasts that are CD41 positive and 61 positive. Very important to know this. This is AML M7 is very frequently asked on the boards. It's associated with marrow fibrosis, so dry tap, no bone marrow aspirate may be obtained, and will be CD41 and 61 positive and associated with translocation 122. Secondary AML. Prior exposure to one alkylating agent, such as cyclophosphamide or melphalan, may cause MDS and could take up to 5 to 10 years to develop AML, 5q or 7q deletion. Topoisomerase 2 inhibitors, such as etoposide and anthracyclines, develop the translocation 11q23, the MML, acute myelogenous leukemia, within 2 years of treatment. That's why some advocate not using anthracyclines in the adjuvant treatment of breast cancer any longer. At poor risk, consider myeloablative allo stem cell transplant. Cranial irradiation, long latency with chromosome 11 translocation will cause malignancy, not AML. Treatment of AML in the quote-unquote elderly, more than 60 years old. Case report. 75-year-old man, newly diagnosed with acute myelogenous leukemia with poor cytogenetics, complex, otherwise only mild hypertension, and is requesting treatment. Older patients may achieve a complete remission with initial standard high-intensive induction regimens, which is the 7+3, but long-term survival is dismal, less than 10%. Therefore, induction with 7+3 in the elderly is controversial. Nevertheless, if one decides to treat, then do not attenuate the induction dose. You may have to reduce the high-dose ARC consolidation as the elderly develop cerebral toxicity with no proof that high-dose ARC improves survival in patients more than 60 years old. It is preferred to achieve complete remission or partial remission with low-intensive therapy, as opposed to high-intensive therapy, and to control the disease as long as possible and reduce treatment-related toxicity. Low-intensive treatments include 5-azacitidine, subcutaneous ARC, clofarabine, and lenalidomide. Transient, a myeloproliferative disorder of the newborn, TMD. Case report. Newborn infant with Down syndrome presents with elevated WBC count and blast resembling AML M7 morphology with trisomy 21. How to treat. TMD is a form of leukemia that almost exclusively affects newborns with Down syndrome. Infants with Downs may develop TMD, which cannot be differentiated from AML by morphologic criteria. Blast will resemble FAB classification AML M7, the Megakaryocytic Leukemia. In the majority of the cases, the number of blasts gradually decrease, with blast and platelets abnormalities spontaneously disappearing before 3 months of age. There is, however, a risk of progression of hepatic fibrosis. Treatment, with observation that TMD will spontaneously resolve within a few weeks. If signs of hyperviscosity are present, then consider exchange transfusion or low-dose ARC. Nevertheless, may go on to develop acute AML later on. Pregnant women with AML. Case report. Woman in 5th month of pregnancy presenting with shortness of breath and pancytopenia. WBC 17,000, 90% blast, hemoglobin 7.9, platelets 22,000. Diagnosed with inversion 16 AML. How to treat. It is acceptable to treat women in 2nd or 3rd trimester with standard Induction treatment. Do not treat women in first trimester with chemotherapy as it is teratogenic to the fetus. This concludes the lecture of acute myelogenous leukemia. Thank you.